We would like to present a video of transvaginal natural orifice transluminal endoscopic surgery, pelvic paraaortic lymph node dissection, and omentectomy in a patient with ovarian cancer. A 50-year-old female with gravidity 2, parity 2, vaginal delivery 2, and body mass index of 26.56 kilograms per square meter presented with complaints of pelvic pain. Ultrasound and MRI revealed a 30 by 23 millimeters complex mass with solid areas and contrast enhancement in the right ovary. Firstly, vNOTES hysterectomy and bilateral salpingo-oophorectomy were performed. The uterus and the right ovary, where the mass is located, will be seen on the screen. Hysterectomy and bilateral salpingo-oophorectomy were completed by transecting bilateral cardinal ligaments, uterine arteries, round ligaments, and infundibulopelvic ligaments. Although the frozen section showed serous ovarian cancer, the final pathology result was awaited because the patient and her relatives did not accept staging surgery. Intra-abdominal examination revealed no evidence of metastasis. In the final pathology, low-grade 4.5 to 4 cm FIGO stage 1A ovarian cancer was reported in the right ovary. vNOTES staging surgery was planned. The previously placed suture was opened. The surgeons entered into abdominal cavity, and a vaginal platform was placed. The right pelvic peritoneum was incised, and the retroperitoneal space was entered. Ureteral dissection was started. The dissection of the retroperitoneal space was extended to reveal the main pelvic structures and marked on the screen. After dissection of the major anatomical structures, harvesting of the lymph nodes was started. To harvest the obturator lymph nodes, the obliterated umbilical artery was grasped. The obturator nerve was exposed by dissection under the external iliac vein, and a right obturator lymphadenectomy was performed. After completing the right pelvic lymphadenectomy, the same procedures were performed for the left pelvic lymphadenectomy. Lower paraaortic lymph nodes were harvested using traction. The peritoneum over the arteries was incised, and areas for paraaortic lymphadenectomy were created. The reason it was not possible to reach the area above the level of the inferior mesenteric artery from the vagina with surgical instruments, 5 mm suprapubic trocars were placed. You can see the right ureter on the screen. The right ovarian vein was coagulated from its entry into the vena cava, and the peritoneal dissection was extended to the level of the left renal vein. This vein can be seen marked on the screen. Duodenum is an important anatomical structure for paraaortic lymphadenectomy. Another important structure that needs to be protected is the inferior mesenteric artery. Inferior mesenteric artery dissection was performed carefully, and the hypogastric nerve fibers were preserved. For paraaortic lymphadenectomy above the inferior mesenteric artery, dissection should begin after lateralizing the left ureter. For en-bloc harvesting of paraaortic lymph nodes, all areas were created, and then paraaortic lymph nodes were harvested. Finally, omentectomy was performed by separating the omentum leaf from the transverse colon and dissecting the subgastric part. After the omentectomy was completed, it was removed from the body through the vagina. The final image shows the inside of the abdomen after the procedure. In the final pathology, no metastasis was detected in the lymph nodes and omentum. vNOTES surgery combining with suprapubic trocars can perform safely for staging in early-stage ovarian cancer. This video presentation is the first in the literature in a patient with early-stage low-grade serous ovarian cancer. Thank you.